let's begin with. And first of all, I would like to thank Ataxia Society for giving me the opportunity as well as our college the opportunity to associate with you all and to do the service with respect to creating the awareness and guiding the students. Thank you. So to begin with, I think already we have dealt with few of the things with Ichapuya's session. So ataxia itself, it's not a very, we can say it as a diagnosis. It's a sign or a clinical manifestation which implies that there is disorder of a movement or affection of the gait and balance and coordination. So types of ataxia, almost we have spoken about it during Sir's lecture that we have cerebellar ataxia, sensory ataxia, vestibular ataxia, frontal ataxia where the frontal cortex is more or less affected, which leads to some planning problem with the movements. And especially here, you will see some decomposition of the movements. Next is the mixed ataxia. Many a times we get to see the mixed picture, especially in degenerative things, where your sensory system is also at stay, as well as the cerebellar system is also at the stay. In such cases, we call it as a mixed ataxia. So coming to the focus of the history when we are dealing with almost, I think, with the symptoms and everything, Sir has briefly touched about especially the symptoms that we get to see in cerebellar ataxia as well as sensory ataxia. If we would just ask anyone of here, may I, if I'm allowed to, someone who can share it. तुमचा एक्सपिरियन्स तुमचं डायग्नोसिस म्हणजे केव्हा झालं कसं झालं वगैरे.
हॅलो
या हॅलो
मला मी नवीन असताना मलेरियामुळे डिहायड्रेशन स्टार्ट झालं त्यामुळे शरीर अटॅक हे झालं आणि त्यामुळे हळूहळू वाढत गेला माझं शिक्षण ग्रॅज्युएशन पर्यंत आलं पण नंतर मी 2004 पासून फिजिओथेरपी केली तर तेव्हा मला भरपूर चांगलं वाटलं पण ती काही मी कंटिन्यू करू शकलो नाही जास्त वेळ कारण नंतर माझा प्रॉब्लेम खूपच वाढला फायनान्शियल पण पैसे त्यासाठी सर्व खर्च पण लागत होता आणि आम्ही काही फायनान्शियली त्यामुळे मला मी फिजिओथेरपी शिकून घेतली आणि घरीच करत होतो तर आता मला आतापर्यंत मी घरीच एक्सरसाइज वगैरे करतो आणि
तर तुमचं डायग्नोसिस आणि सिम्पटम्स म्हणजे जेव्हा तुम्ही किती अंतर होता पटकन झालं डायग्नोसिसची वेळ लागला डायग्नोसिस व्हायला
डायग्नोसिस व्हायला वेळ
So that is what the point is, what where I was intending to highlight that the diagnosis is not very easy going, and especially when it comes to the type of ataxia, types of cerebellar ataxia, it takes time, need to go through many investigations and everything. And especially when we talk about any new neurodegenerative condition, especially like cerebellar ataxia and everything, you'll see that the patient's diagnosis, it takes time. The symptoms comes and more or less we ignore the symptoms in the initial phase of our life unless and until जोपर्यंत symptoms एवढे वाढले असतात की ते डे टू डे लाईफ मध्ये इंटरफेअर करतात आणि तेव्हा आहे ते की आपण डॉक्टरकडे तेव्हा जातो. सो द डायग्नोसिस itself takes a time to be done, and then there are tests that need to be done, and I think ma'am is going to speak about the genetic part of it. So to diagnose about the type, then you have to go with the genetic things and everything. So it takes time. But and if you talk to these patients, they will have a great amount of file with them. I have shown to this doctor, I've shown to that doctor, I've shown to that doctor with the hope of cure that someday something will definitely happen. But let me tell you all that please do remember, as Sir said, if it is not curable, no issues with it, but there is something that can be done. So please remember that the quality of life definitely can be improved, and that is the foremost goal of the physiotherapy to deal with such patients. So please remember that even in the word disability, there is the word ability. So that is where we have to focus on what are your abilities and what we can do with those abilities to make the patient more and more independent. So with the assessment part, when we are taking about the history, the highlight points should be, since when you are having this symptom, is the case acute, is the case subacute, or is the case chronic case? Is there a symmetrical involvement or bilateral involvement, one side more than the other, or is it going same? What's the rate of progression? Static hai, episodic hai, aata hai, jata hai, especially such scenes are seen in multiple sclerosis and other things, or it's a progressive form. Then associated features, headache, vomiting, dystonia. So it gives you an idea about multi-system affection or the other system coming into the picture. Then the medical history, infection related hai, kya medications chal rahi hai, environmental exposure. There are some specific things, mercury exposure or other exposures that can lead to degeneration of the cerebellum. Then the family history, which gives us idea about the genetic thing, ki is it getting, it has a hereditary thing or not? Because when you come to know that there is some familiar things and everything, you please see to it that they are going through genetic counseling, which is a real missing part in India. I would really say they don't opt for genetic counseling, and the things pass on, and pass on. So please emphasize towards getting the family history from the patient. Next is checking for the higher function. As already mentioned by sir, we know that the speech and swallowing gets affected in them. So you have to check with the higher functions, and sometimes cognitive affection you may get with them. Then you have cranial nerve assessment, where you have to specifically emphasize on certain nerves, which are your, as we were seeing that we have nystagmus and everything. So we have to focus on optic, oculomotor, trochlear, trigeminal, vestibulocochlear nerves. These are the specific cranial nerves that we need to assess and find out the things. When you come to know that there's the speech affection, or you see that the beginning of speech affection has started and everything, please, I am again re-emphasizing that when we talk about rehab is always multidisciplinary. It's not a single hand job. So please see to it according to the symptoms of your patient, and we are here managing the symptoms. So see to it, identify the symptoms and guide your patient accordingly. As I said, genetic counseling is important. Same way is speech and language pathologist referral is also important. And as mentioned by the sir that there is some already he's there who's already taking a speech therapy session for everyone. So it is really important. Imagine I want to speak something, and if somebody is not understanding it, I feel so much that I cannot express myself, because speech is a medium of expressing yourself. So please see to it that you refer the patient there and there, or you can opt for online, which is a boon with COVID, I guess, these virtual sessions and everything. So even they can go for that particular thing. Then you have your motor assessment, which includes tone, reflexes, range, power, tremors, coordination, which has your equilibrium and non-equilibrium test. I think I need not to go in detail. More or less, the crowd is either masters or the patients. They already, and this is also magic with the neuro patients, that half of the assessment, even they can tell you, my doctor did this test with me, and he has seen this and this thing. So coordination followed by balance. So balance, you have lot many outcome measures. You can opt for one or two of your outcome measures to assess the balance with the patient. You have work balance, functional reach test, time up and go test. Then you can go for gait assessment. Already, I think it's been highlighted by sir that we can see ataxic gait, which is a wide base gait, and you sometimes called as a drunken gait, sort of a thing that patient is going like this while walking. Or if sensory ataxia, you have a typical high steppage gait, which is a classical feature of it. Fatigue is one of the most common. As the disease progresses, the fatigue sets in because the muscles are getting weaker. Day by day, the activity level is getting reduced, and that's how the fatigue sets in. Then you have functional and for assessing the functions, you have FIM, Barthel Index, and you have some specific scales which are meant to assess for the ataxic patient, or especially the cerebellar ataxic patients. One of them is the scale of assessment and rating for ataxia, which is SARA scale. Once you have done with your assessment, please see to it that you are formulating your ICF, which is International Classification of Functioning. So now here we know that my patient is having a disorder of movement and balance and coordination secondary to cerebellar degeneration. Just for an example, body function affection that you are going to see is reduced tone or in coordination and many more such things in your structure and function, degeneration of the cerebellum. Now, activities, what are your problems? So, please, as a physiotherapist, our main goal or mainstay comes here when we have to see about activity and participation. What activities, दिन की क्या क्या एक्टिविटी करते वक्त आपके पेशेंट को प्रॉब्लम हो रही है, उठने में प्रॉब्लम हो रही है, चीज को पकड़ने में प्रॉब्लम हो रही है, चाय को पोर करने में प्रॉब्लम हो रहा है, चम्मच से खाने में प्रॉब्लम हो रहा है. So focus on the activity, from the activity and the participation plus participation. What was his job profile? What was his recreational profile before having this disease or before having the symptoms? Try to find out what are the hobbies, how much the patient participate in his hobbies and other things. Next, see to it that what are the environmental and the personal factors. Sometimes we well know we are towards developing those things, but till date our community is not very much functional with wheelchairs. We cannot take wheelchair each and everywhere. Few malls have that facilities of elevators and everything, but not everywhere. So please identify are the environmental problem which is restricting our patient participation, or for example, simple thing, attaching a railing. I think in this kit they showed about home modification, just putting a railing during your side, I mean walkway or near the toilet can help the patient to hold, get up, sit down, which gives the patient independence. So please identify, but how are you going to identify unless and until you don't ask for it? What is the facilities at the home? What is the facilities that you have at your job? Please identify everything and then for treatment accordingly. Something as we say ना कि कुछ भी करो करके दिखाओ, भले ही साम दाम दंड भेद कुछ भी यूज करना हो, it's the same thing. You can choose your strategy. Sometimes restorative strategies will work, sometimes compensatory strategies would work. So this all environmental modification, giving them aids are part of your compensatory strategy. So identify why activity is limited or why the participation is limited. What is at the problem? If it stability at the problem, treat stability. If along with some compensation can give your patient independence, focus on that. So for that, you need to really have your ICF in the picture. And if you really see, you have to have your activity and participation as the mainstay, followed by relating it to the impairments and contextual factors. What are the problematic cause and hit that particular area so that you get the right result. So as already mentioned, we have goals. So to improve quality of life is our major goal, which we have to focus on. And as I already said, we have either restorative strategies or compensatory strategies, and sometimes a combination of both of them. So coming to the principle of the treatment or the training, there are very simple things that we really need to keep in mind, that see to it that our exercises are simple, and then we are moving from simple exercises towards the complex exercises, because already we have seen they have dyssynergia and decomposition of movement. So we should target simple exercises first, followed by complex exercises. Exercises should be practiced with eyes open first, followed by eyes closed. See to it that you have your proximal stability worked first, or work on proximal stability along with the distal movement. If we see, that's the pattern of our normal neurodevelopment also. If you see a child, he develops some static postures first, and that too with broad base, and then the finer movements come in. So if you want to see a movement or a mobility spectrum altogether, so we have something called as, you have a stability, then you have a mobility, and when you have stability and mobility combined gives you a controlled mobility, which we called it as a graded control. So if I want to paint a painting, I need to have a graded control. If I want to apply a toothpaste on my brush, I need to have a control. Otherwise, it will spill more or less. If I want to apply a lipstick, I need to have my graded control, where my hand is going, how much is my force. Otherwise, it will be somewhere light, somewhere a darker one. So that is what is called as a graded control or a controlled mobility. So see to it that you are targeting on. And when we see ataxia as a term, here the problem is your stability is your problem, not the mobility. Here the problem is not ranging more with your mobility. It's the problem with stability and controlled mobility. आप उनको बोलो हाथ ऊपर उठाओ, it's not that उनका shoulder का range restricted है और वो हाथ ऊपर नहीं ले सकते. If we had seen just now while stretching, everyone was able to take their hand up. So it's not the movement, mobility per se is at the problem. But if I would have given them a target key, you have to specifically touch this target or lift this particular thing, maybe they would have some problem. So that is what is stability and controlled mobility is what we have to focus on during our training. Next is sometimes we have to use our compensation methods, which are your supportive aids or devices, and some environmental modifications. And as already mentioned, we know now this neuro rehab is going to go a way long with them for whole of their life or whatever thing. So we have to see to it that, and in one session we cannot have all the exercises done. So either you can have your part sessions at the home where you can give them home exercise program, alternate sessions as per the patient's call. So we need to even focus on our home exercise programs. And please, one more request to everyone, whenever you are giving a home exercise program, see to it that you are mentioning the exercises in details. Since then the smartphone came in, patients do ask, can we have the video of your exercises? With your consent and everything, if you are okay with it, please see to it that if you are passing on the videos and they are taking the videos, do cross check. They do learn the therapy, the relatives or the helpers of the patient, but not necessarily they are doing it in the correct way. So if you have given them, see to it that ask them to demonstrate the things in front of you so that you are cross-checking that they have understood it well and they are doing it in the correct manner. Please make your sessions more and more attractive, have more new exercises, some more new things for them. Maybe the goal is same, but the exercises can be changed rather than having a monotonous exercises. So with respect to the types of ataxia that we have seen, there are few specific things that we need to consider. So for example, when we are dealing with sensory ataxia patients, we need to focus more towards improving the proprioception and emphasizing them on using their visual system more. As sir had already said, if you see sensory ataxia patient, he would be able to walk with high steppage, and as soon as you ask your patient to close the eyes and do the thing, the quality of the movement deteriorates more because you are removing the visual system from the movement. So when we are focusing on sensory ataxia, proprioception and visual aid is our main stay of focus. When we are talking about cerebellar ataxia, we have stability training and extremity ataxia training as our more focus. When we are dealing with vestibular ataxia, we have some habituation exercises and gaze stabilization exercises followed by some balance exercises for them. And when we have mixed ataxia, we need to incorporate different things along with the things that we have discussed right now. So moving next, now if when we are talking about to increase the proprioceptive input, so we have choose exercises which are in your weight bearing position, whether it be quadruped position or plantigrade position, standing position, sitting with one hand support and other move doing the movement. Specifically go with weight bearing position because weight bearing gives lot of proprioceptive input. Next is your PNF strategies. We have lot many techniques in the specific PNF thing that emphasizes on stability, where we have rhythmic stabilization, slow reversals, and resistive exercises. So we'll just go in brief with video. So this is some basic exercises in lying position. I hope the video is good. Yeah. So this is the bridging, and followed by breathing. In the breathing itself, then you have is resisted breathing. You can even go with reversals in breathing to build the stability, pelvic stability. Please see to it that when you are choosing this breathing exercises or exercises in line are the chosen exercises when the patient is bedridden. These are not the ideal exercises for the patients who are mobile or who's able to walk. Fine. So choose your exercise wisely. Even if I'm showing the video doesn't mean that you need to copy paste each and every exercise with every of the patients. So same is with the lying position. So even if a patient is bedridden, it's not that we cannot do anything. Still, we can maintain the muscle strength, muscle properties, and movement with our patient. So again, reversals in your sideline position. Next is your quadruped position. So weight shifts in the quadruped positions. Then again, some reversals in the quadruped positions where the patient is supposed to hold the position so that the static stability is built in the patient. Then we have quadruped functional activities, some reaching targets. And the target is a weighted target. It's not a very light target because even the weight helps to provide the stability. Some exercises in sitting. Then standing, again, approximation. You can use approximation to make your patient stand. Making the patient erect and then giving approximation to make your patient stand. Then you have some weighted techniques where you are adding weights, seeing to it the patient's strength, how much the patient can cope. This reduces, especially, these are the techniques that really works in postural ataxia or truncal ataxic patients where you can use such techniques of weight, giving them weighted jackets or compression jackets. Then same is with the walking, resisted walking, walking with weight in hands. Again, you have to reduce the degree of freedom in such patients so that you are focusing on more with the stability because stability is at the problem. So they cannot do lot many activities or complex activities while walking. So you can apply weights, you can give weights in their hand, or you can give some devices to hold on like walker and everything which reduces their degree of freedom but provides stability to them. Then you have some pressure garments with you, which can be prescribed to the patients. Nowadays, very thin lycra pressure garments are also available in the market. Again, this also helps very much with truncal ataxia patients, where it gives a good great stability to the trunk. Even you have theracots, which can be applied to the extremity, which gives compression and lots of proprioceptive inputs for the patient that you can use with your extremity ataxia. Next is already we have discussed with this proximal stability, then moving towards the dynamic movements, having broad base, then moving towards the narrow base, change in the position of center of gravity, and you can make the task difficult for your patients as the patient is progressing. Aquatherapy is a real great boon with ataxia because the buoyancy in the body weight is reduced and the hydrostatic pressure from all the directions gives more stability in the water. So aquatherapy, tai chi exercises, yoga, even your postural devices, I mean posturography or balance masters are the aid which can be used provided you have that facility at your rehab centers. Otherwise, you can use the other ones. Next is extremity ataxia. You have rhythmic stabilization techniques, Frankel's coordination exercises, and combination of isotonics. Combinations of isotonics are well and great chosen exercises when you really need to develop a graded control in your patient. So fine, again you can see it's a weight bearing position where both the limbs and one hand is in support and one hand is given a weight which can be used to touch the target and reduce it. And you can ask the patient to hold it in the air where you are building on the proximal stability. So going up, hold, coming back. It's a combination of isotonics for your patient. You can try with weights, you can try without weights, whatever suits to your patient. If fatigue sets in, weights is not the right choice to go with. You can use therabands. I think the video is. So the patient has been applied with the therabands all over so that resistance is provided. This is resisted walking with same theraband to improve the stability. Next, you have lot many adaptive devices available in the market which increases the grip or which make the object a heavier one to provide stability. Simple modifications like in applying a guard to the plates or giving them deep bowls to eat the food reduces the chances of spilling the food outside. So though they sound very silly and small, but it makes a huge difference. Make changing the spoon and the utensil changes give them the freedom of feeding themselves, and having feeded one own self they feel really great that they have achieved one milestone. It is very easy for us to say that it's just to have this and have food, but it is a milestone for them that I ate myself after a long. There are a lot many mobility aids available in the market that can be prescribed to the patient according to the stage of your patient or the level of your patient. So you have normal wheelchairs, you have motorized wheelchairs, you have mobi bikes nowadays, then you have walkers, then you have something called as assisted robotic walking, which is the last picture. So even the evidences, I think already my job is half done by our president of the society. She already emphasized on physiotherapy importance. Also, sir has also emphasized on the importance of physiotherapy, and here is the evidence, which also says that therapeutic exercises and the rehab have moderate evidence, low to moderate evidence to improve the quality of life of a patient with ataxia. Then there are now this exergames, or you can call it as video games or exercise-based games, which really helps even with your extremity ataxia as well as your truncal ataxia. Next is already I spoke about aqua therapy, which includes even swimming and exercises, ice exercises in the water. Next is robot-assisted gait training in the patients with ataxia. Even they found a good result with robot-assisted gait training. Plus, there is this thing called as ground robot-assisted gait training, which the picture that we have seen, it has a motorized control in, but everything these are in studies and yet not proven very well. Though they really help to improve their quality of walking, but how much they are okay to be used in the community and how much or what areas they can use it, donning, doffing, weight of that particular device is again a problem. Studies are going on to reduce the weight for the object, but still not yet totally done. But this can be an option given to the patients who all can go with this option. Thank you.